Let's now review our thiazides, and we'll start as usual now with the classic figure that we've described several times at other portion of our tubule. In the actions of thiazides on the distal convoluted tubule, we now want to focus on the luminal membrane and the sodium chloride symport that occurs there. Although this is only 10% of sodium that is reabsorbed at this level, it still remains the target of thiazides. By inhibition of this pump, thiazides cause sodium and chloride to remain in the tubule, and for osmolarity, water stays and we see an enhanced diuresis. Now, certainly the diuretic effect of a thiazide is not expected to be enormous, being that you have very little salt and water that remain to be absorbed here. But it still qualifies for the definition of a diuretic. Another point is shown here by the diagram. You see that this sodium that is reabsorbed in the distal tubule is then, as usual, pumped out in the body thanks to sodium-potassium ATPase, essentially reminding you a point of physio. Transports of salts in the kidney tubule are by far associated with secondary active transporters that rely upon the ATPase activity of the sodium-potassium ATPase pump. But another pump is important here. You see at the bottom of the basolateral membrane the famous sodium-calcium exchanger pump. We visited this pump before in the heart muscle, and we had explained then how reabsorption of calcium could only occur thanks to an electrogenic gradient created for sodium by the sodium pump. Let's think at what would happen if thiazides were given. If thiazides are given, then because less sodium comes in from the luminal side, with less sodium coming in from the luminal side, the gradient is more favorable for sodium to come in from the basolateral side. As a result, if calcium is available in the distal tubule cell, then there would be more calcium reabsorbed when thiazides are there. This is going to be the reason why thiazides result in hypercalcemia. There's only a little problem with that hypercalcemia. We need to have calcium in the distal tubule cell, and the only way calcium gets here is if there is a calcium channel in the luminal membrane of a distal tubule. Well, these calcium channels are the ones that are PTH dependent. That is, in situation of hypocalcemia, you know that the parathyroid will produce PTH, and PTH will bind to GS-coupled receptor on the basolateral side of the distal tubule. The increased cyclic AMP will then phosphorylate these channels, open them, and allow calcium to get in. Then calcium is exchanged for sodium to be retained in the body. This is one of many ways by which PTH can restore calcium levels. You know, other ways are increased osteoclastic activity and increased activation of vitamin D, namely its 1-hydroxylation by kidney cells, in order for vitamin D to allow more calcium reabsorption from the gut. In a nutshell, when thiazides are given, the excess calcium entry can only occur providing PTH is there. That might be a reason why the hypercalcemia from thiazides has never really been shown as being beneficial in people with osteoporosis, since it would still require PTH presence, which in and of itself only happens when there is hypocalcemia. And just remind me a key point of pathology there. In osteoporosis, is there a change in blood or urine calcium and phosphate? I hope you're telling me no. We're not talking osteomalacia here, we're talking osteoporosis. Maybe that is simply the reason why there is no net effect on prevention of osteoporosis by thiazides. The drugs. Well, they often sound like thiazides, so they tend to be easy to recognize, such as hydrochlorothiazide. But some don't. Look, for instance, at the drug indapamide. We know their mechanism. They block the distal sodium chloride transporter, which will increase luminal sodium and chloride and therefore enhance diuresis. Their use is mainly hypertension and adjunct in CHF. Now, why are they used in hypertension? Is it again the diuretic effect? Not really. A little bit like for loop diuretic, thiazides are powerful vasodilators. And the way they vasodilate this time has nothing to do with prostaglandins. It has to do with ATP-dependent potassium channel opening. Boy, now that should ring a bell. We saw ATP-dependent potassium channel openers as the drugs diazoxide and minoxidil. And you'll keep this in mind for looking at the list of side effects. Now in CHF, thiazides can be relevant to decrease edema fluid, of course, to fight high blood pressure. They're used also in kidney stone, nephrolithiasis, providing those calcium stones, since they allow calcium to be retained by the body rather than being left inside the renal tubule. A final use of thiazide that is often counterintuitive is in endocrine. Thiazides are the treatment of choice in nephrogenic diabetes insipidus. Now, how could that be? Well, let's first talk about diabetes insipidus. This is a situation, when called nephrogenic, where ADH is produced, but ADH receptors do not function. When ADH receptors don't work, we know that then large volumes of hypotonic urine will be released by the patient, causing eventually some dehydration. In order to try and prevent ADH to have any work to do, since it doesn't work, a key issue is to remove the free water sooner. Well, if you give a diuretic acutely, you would enhance sodium excretion and therefore maybe worsen diuresis. That's why we need to use a weak diuretic, such as a thiazide. And the rationale behind the use in diabetes insipidus is to think of the diuretic under chronic administration. If you chronically force the kidney to lose more sodium, we know that then the distal tubule and collecting duct will try and retain sodium more, often to the expense of potassium and protons. But in doing so, the free water that was prepared proximally, particularly in the thick ascending loop of Henle, will then be reabsorbed before getting to the segment of the collecting duct where ADH is supposed to do its job. So overall, chronic administration of a diuretic actually will decrease the work required for ADH. Well, this is why we use thiazide diuretics in the treatment of nephrogenic diabetes insipidus. What are side effects? Well, with a name like thiazide, no doubt, sulfonamide type of hypersensitivity. Like all diuretics that work initially in the tubule, hypokalemia and alkalosis. Make sure you underline well the hypercalcemia, contrast to the hypocalcemia we mentioned for loops. We understand the hyperuricemia because of competing with urate for excretion. We're left with two side effects to understand. And I think this is where you're going to find handy the way thiazides work in hypertension. Do you remember? We said thiazides are potassium channel openers, particularly of the ATP-dependent type. If you remember well, when we saw diazoxide and minoxidil, which were used in hypertensive emergencies or in severe hypertension for this mechanism, well, we saw that the same channels were on beta cells of the pancreas, and opening those potassium channels would suppress insulin release. If you suppress insulin release, you understand the side effect of hyperglycemia. Can you also understand from your biochemistry the side effect of hyperlipidemia? Let's see. If I have less insulin, number one, after a meal, am I going to be able to store fat as well? Well, the answer is no. And number two, when insulin is low, the key lipase that will be turned on is hormone-sensitive lipase, which will constantly mobilize fat in the patient's blood. As a result, in your book, thiazides are said to cause both hyperglycemia and hyperlipidemia. Now, hyperglycemia and hyperlipidemia mean you should not use thiazides in diabetics. They are diabetogenic, and you should not use thiazides in people with high lipids. This is an issue since we love to use thiazides in the initial management of blood pressure. And a little bit like you learned for beta blockers, there are some notable exceptions. And for thiazides, the drug indapamide is devoid of hyperlipidemia. It would be your best choice if lipid profile is an issue in your patient. Now, there are a few drug interactions and cautions for the very commonly used thiazides. Don't forget digoxin. Digoxin could see an enhancement of its toxicity due to electrolyte disturbances, here particularly the hypokalemia. Remember, it's true also with loop diuretics. Otherwise, you understand well why we would avoid thiazides in diabetes.